Hi, and welcome to this video snippet on pain behaviour. So we'll be looking at how pain behaves, external factors, and how it behaves amongst itself. It'll become clearer as we get into this further. So this is basic stuff, and you'll get a lot more of this during the whole program, actually, not just the next course. So the first thing to ask is whether pain is constant, continuous, or intermittent. Constant pain is pain that doesn't change. Now, you can talk about it not changing over time, or you can talk about it not changing under different conditions. Most pain will change over time, but if we look at a set period, say a day or so, then it doesn't change within that day. The other way of looking at this is that regardless of what you do, the pain doesn't change. Now, often constant pain is given as severe inflammation. So a hot, swollen knee gives you a constant throbbing pain. Try standing up on that leg and jumping up and down and seeing if that pain actually is constant. It isn't. It's continuous. The pain goes on and on, but it isn't constant. It gets better and it gets worse depending on what you're doing to it. So constant pain actually indicates fairly severe disease processes, visceral and so on, but it's not a good thing. Continuous pain is pain that's always there, but it goes up and down, and inflammation does this. You have a sort of a baseline pain, and with outside of that baseline, depending on what you do, if you rest it, the baseline pain sort of drops a bit, and things feel a bit better, but not much. But if you do stuff to it, then the pain goes up. So it's like a level thing that goes up, comes back, goes up, comes back, comes up. Intermittent pain is pain that's there sometimes and it's not there at others. Of these three, though, constant pain is the rarest of them, and it's also the one that indicates the most serious diseases. If you haven't got a hard diagnosis that makes sense, I would assume that constant pain is something serious and have it looked at in more detail by the physician. Irritability. This is a reaction that's provoked by a stimulus. So you do something and then it aches for a period of time afterwards. It's a pain when you do it, but it aches afterwards. So it's irritable. Now, the longer it aches for, the more intense the pain while it's aching, and also the seriousness of the stimulus all go to tell you how bad this irritability is. And irritability is really about inflammation. The onset of the pain, it's just sudden or gradual, and is it related to trauma? So significant trauma followed by immediate severe pain, that's probably the worst pain you're going to feel at any point during this whole process, indicates a healthy tissue injury, a fracture, a muscle tear, a ligament tear, but something has been disrupted considerably. So you get that immediate severe pain, and after that, it never quite gets that bad again. That's not a good sign. It usually does indicate something traumatic. Now, you get similar sort of things with degenerative type tears and fractures, and even pathological tears and fractures, although the severity of the pain is generally a lot less than a healthy tissue fracture or tear. But nonetheless, the onset is sudden. It may not be that severe because the pathology or the degeneration has weakened the bone so much that nociception doesn't play a huge role in it. So the pain may not be too bad, but nonetheless, it's as bad as it's likely to get. Both of those, then in that case, that indicates a non-healthy tissue disruption. Is the pain related to movement or posture? Generally speaking, with mechanical problems, it's both. I can't run, but if I sit for too long, it'll ache. Or if I'm watching TV with my head turned in an angle, then it will gradually ache more. When does it hurt you most? When I'm doing stuff, when I'm running, when I'm bending, when I'm doing something. This is when I get the sharp pain. Otherwise, it tends to be an ache that is often referred. With visceral problems, it's interesting because general movement can often relieve the visceral pain, while staying still actually tends to allow that pain to get worse and worse and worse. What are the aggravating and relieving factors? Well, with mechanical problems, the aggravating factors are generally movements and to a lesser extent postures. relieving factors is essentially not doing those things. If you're getting anything other than that, you've got something a little bit strange going on. If the aggravating factors have nothing to do with specific movement of body parts, then you want to be careful of that. For example, somebody would check back pain, upper back pain, who gets pain when they're driving or sitting, but not when they're actually twisting and turning. This may be cardiac, or it may be another viscera, but it's unusual for a mechanical problem to do that. Is it coupled or decoupled with other symptoms? Now, if the two symptoms are strongly coupled together, that is, you always have both of them together, you never get one without the other, then they are associated, and they probably are coming from the same source. So if we can see something like this in the neck, with a mechanical dysfunction of the neck, you can get a headache and type 2 dizziness in particular. So lightheadedness along with that headache. Now, you're also going to get neck pain because that's what the patient's primarily in there for. So the question is now, are they all linked to the neck pain? Now, if that's the case, probably the neck pain is causing all three, particularly if the neck pain is always there, but the headache and the dizziness are not. Then it may be that the other two symptoms only come on when the neck pain is particularly bad. Or the other two symptoms may come on with postural stuff, which is exactly what happens to referred symptoms. So in that case, they're linked up. The worst coupling we'll talk about in a second on the next slide. So does the pain cause obligate or non-obligate functional loss? So if the patient can't do something, for example, then that intense pain is actually very real. Often they'll tell you how bad the pain is to the 10, but they can do everything they want to. So subjectively, the pain is severe. Objectively, based on their functional status, it's not that bad. So this is another indication that you want to be very careful about this. Okay, so let's have a look at some conditions that may cause problems to see how the body reacts as far as pain's progression is concerned. So infections, intracranial bleeds, growing tumours, the pain gradually gets worse, or maybe not so gradually, but it will progress over time. So it worsens both in intensity and in spread. This is not a good sign. If you see it with a disc herniation, for example, and it's starting to go down the other leg, you have to start worrying about median herniations or compression on the cord requiner. So this is not a good sign. It's a progressive pain. Progressive headaches are always a bad thing. You should never accept a progressive headache as a normal variant of a cervicogenic headache. It really isn't. Spondylogenic headaches get bad within a day. These things can keep on getting worse. So a bleed can occur very rapidly, in which case you're not going to see them in the clinic, but slow bleeds can take 3 or 4 weeks before the patient collapses. So they're a gradual progression. So if you see them 2 or 3 times over a week, and this pain is still getting worse, and they're not doing things to aggravate it, so they're doing everything right, then this is not a good sign, post-trauma anyway. Visceral primary bone cancers, this pain can be constant in both cases. Whereas, again, I'm talking about constant now and its response to stress. Primary bone cancers can be quite small. These tend to occur in children, but they can be quite small, and in the initial stages anyway, they may just be tender to touch. So palpation is tender, but often stressing the bone isn't. It's just not big enough for that sometimes. And of course, visceral pain, your body movement's really not going to do very much to it at all. So this is something else you want to get out. Inflammation. The pain tends to be a continuous baseline pain that goes up and down, but there's always pain present, and it generally holds a similar sort of level if it's bad enough. If it's not too bad, that baseline pain will go down low to the point of almost disappearing sometimes, and then come back up again. And of course, it's irritable. The more severe the pain, the higher the baseline pain and the higher the irritability. It worsens with increased activity. And if this is a systemic pain, such as an acute flare-up, for example, this turns constant sometimes, and because it's just so bad. And basically, if you've got pain and stiffness there for over 2 hours in the morning, you need to start thinking about systemic conditions. Mechanical problems, posture presents an ache, and movement tends to produce a sharp pain. Now, the intensity of this, in part, is very subjective, of course. The patient's own subjective responses to nociception is one thing. But the amount of aching will give you an idea of how much pain this subluxation is actually producing, it, regardless of what the patient's saying. It's not to say a local pain isn't severely painful, but if they're getting referred pain, the chances are that their pain is also fairly acute. Mechanical pain is aggravated by specific activities and specific postures, but it's also not really relieved by anything else other than not engaging those activities and finding a comfortable rest position. But it's mostly the avoidance of those rest positions. Coupled pains are from the same source. Decoupled pains are from different sources. This becomes really important when we're looking at something like VBI and the relationship between headache and dizziness and neck pain. Disc herniations, you have flexion and extension impairments. They can't do either. They have an obligate functional loss, but neither flexion nor extension is free. And whereas with biomechanical dysfunction, typically it's either flexion or it's extension, but it's not both. Now they may, one will dominate. They may say, okay, so running is my biggest problem. I get sharp pains there. If I sit for more than half an hour, my back does start to ache, but running is a real problem. So one of these movements, flexion or extension in this case, will dominate the picture. Both of the, that applies both to the peripheral and to the spinal joints. Okay, so pain behaviours. Now, there's a lot to pull apart here, and we will do that when we meet. Okay, so look forward to seeing you soon. Take care, everybody. Bye-bye.